Thank you very much to our panelists and respondents. One quick thing that I want to mention that has been a theme and a sub-theme in our discussion that I think is important in terms of our discussion going forward, which is the potential role of this empowerment piece in terms of nurses and midwives empowering their colleague workers, and the potential for the wraparound with community health workers and other kinds of women who are working in the health sector. So that's something that I think has surfaced, and I think that is important for us to include in the discussion today. So at this point, if you have questions, comments, please join us at the microphone, and we'll take them and have our panelists and respondents engage. Patrick?
Good morning. My name is Patrick Kelly. Here at the IOM, I'm director of the Board on Global Health, and I very much enjoyed the presentations. As you know, Patricia directs the Forum on Innovation in Health Professional Education. Several of us in the room were part of the Lancet Commission Forum on Health Professional Education for the 21st Century that really inspired that forum. When Beth was speaking, she highlighted some areas of investment, such as in R&D and in hospital physical infrastructure and in mobile technologies. And I wondered, do you invest in health professional education? Is there a market in the for-profit world? You know, in this country, for various and sundry reasons, we provide most education through not-for-profit type institutions. But there's a huge need for workforce. Sometimes the not-for-profit institutions are a bit entrenched and may not be able to create the type of product, human product, that is needed. And I'm just wondering whether there is space for your type of organization to invest in the institutions that would produce the type of midwives that this is all about. And a kind of a related question while I'm up here, I often wonder whether, if we're going to be patient-centered, like Krishna said, whether midwives should have a bit of an expanded role so that they could be not just about the prenatal and delivery period, but also the care of not only the mothers, but the children shortly after. I mean, the mothers and the children are kind of joined at the hip almost literally. And I think for the sake of patient-centeredness and access and quality, there might be some space for creating a hybrid profession that joins midwives with young child care.
So it sounds like we've got three potential respondents there, ending up with Petra and starting with Beth and then Krishna.
Yeah, thank you. And I'd be curious to get Krishna's thoughts on the health workforce investment question as well, given that his interaction with innovators. So, you know, to be honest, we left it out intentionally because we haven't seen a ton of business models that work in kind of the workforce development education space. But we're starting to see kind of glimpses of models that might work or might be kind of starting to create solutions where there is opportunity for investment instead of just kind of grant or donor support for the development of the professional workforce. One of which is leveraging microfinance institutions and looking at how MFIs can create student loan products to allow kind of people who want to go to school for nursing or midwifery or to be a physician to have access to capital to help pay for that education and then be able to pay that back once they get into the workforce, like you see student loans here in the U.S. And so there's a lot of people who are kind of pushing for more innovation on the MFI side to develop those products to get more capital flowing so that people can access education that they wouldn't otherwise be able to access that. And they obviously have, you know, very entrenched networks in developing countries to reach the populations that we'd want to serve. So we're certainly looking at that. Otherwise, we haven't seen, in terms of the organizations that are providing the education, the universities, we haven't seen a lot of kind of business models that we would look at, but we'd certainly be open to them, and I'd be curious to see if you've seen some.
Sure, I think that's a great point about MFIs, and I think one of the best examples we've seen is building off of the success of Grameen Bank in Bangladesh with a partnership with Glasgow Caledonian, and when we were in Bellagio, we had the pleasure of being joined, at least by video, by Barbara Parfit, who moved to Dhaka and created the Grameen Caledonian School of Nursing, again, oriented toward providing nursing education for the daughters of Grameen Bank borrowers, and so leveraging existing microfinancing institutions to create then access to health professions education. I think in a very short period of time has been a tremendous success. So that's more on the formal education side. The other aspect we're seeing has been efforts now. Many of you have probably heard of Narayana Health, which is based in Bangalore, India. And this is Dr. David Shetty. They're famous for doing open heart surgery for $3,000 with the same outcomes as the U.S. And they have created with Ascension Health, an outfit in the Cayman Islands. So they are playing a role now from outside the borders, but influencing how healthcare evolves into the U.S. And at the same time, they have announced their intention to build what they're calling the Global University for Health Professions Education and Training that would leverage common curriculum courses, build competency-based workforce that would try to harmonize the development of health professions education, really oriented toward low and middle income countries to create depth in a cost-effective way in the health professions that are necessary. And we're also seeing not just on the formal education side, but certainly on the training and professional development and workforce upskilling side. For example, LifeNet International is working in Burundi, and they work through a channel of faith-based clinics. And what they do is actually come in and provide workforce training, access to standard protocols, and other ways that the nurses of these clinics are able to increase the scope of their practice in an effective and high-quality manner. So we're starting to see these mechanisms. I think over the next few years there will certainly be opportunities for impact investing into this space because we're starting to see financially sustainable models to work in the education training space.
Petra, did you want to respond as well?
Yes. The last part of the question is a brilliant opening for talking a little bit about midwifery. Thank you for that one. Of course, the midwife always has had the role officially that you described. It is not a hybrid, but a role that fully encompasses the continuum of care from pre-pregnancy to early years or months or weeks of life, depending on context. What's happened is that over the past years, because of the focus on emergency obstetric care, it's really had a much stronger focus on only catching babies, to say it impolitically and unpolitely. So I think there are quite a few things that are should be much wider known and used. And to underpin that, we've just written a Lancet series on midwifery that really lays out every element, every aspect of what midwifery care should be, and that means midwifery as done by everybody who's active in the area of reproductive health, and really stands for being with women. So that's the people-centered element that you were talking about, but that also looks at what are the effective interventions that are provided by midwives and what is their impact on maternal newborn mortality and on stillbirths. And in the series, you'll see that there is a large impact on that, but also there is a large impact on health and well-being, again, from a more people-centered and people-focused, women-focused perspective. We've developed a quality maternal newborn care framework, which not only identifies the things we're supposed to be doing, but also the values with which we do those, which is understanding the community, tailoring needs, and tailoring services to women's need, being respectful, and really focusing on what she needs rather than on the system or on the provider themselves. And the second big underpinning element is the philosophy of care with which midwifery is provided, which really goes towards making sure that we optimize the normal processes of childbirth, pregnancy and childbirth, which are not only the physiological ones, but also psychological and social and cultural and religious processes, and that we kind of maintain, I'll say it in a legal way, in a sense until proven guilty perspective, as in physiology until there's proof of pathology. And I think those are elements that really need to be carried by everyone in the health sector, specifically, of course, involved in maternal newborn health, but that really also go very much further to a full position, a way of being, and a way of conducting your life, which, as I was saying before, goes far beyond women only in their roles of nurses and midwives, but much more as women in their communities and their nations.
Thank you, Petra. Okay, our next question.
Yes, good morning. Carolyn Curtis with USAID. I have a couple of questions and then also a comment to make. I'm very excited about the question that was posed by our previous gentleman and wanted to really emphasize the need for really paying attention to pre-service education, because this will instill the capacity for those midwives regardless of where they're posted. What happens within service education, we put loads of dollars there, but once that person moves from that particular post, the skills and capacity go with them, and then that particular facility is now left deficient in that particular area. The other thing that I wanted to ask about is around performance-based financing. There was a question that came up in regard to quality and standards, and whether or not there could be some look at using performance-based financing to help facilities to be able to function at a particular standard. And I would want to really emphasize the standards that have been put forth by the International Confederation of Midwives. They have, in 2010, basically upgraded their competencies for pre-service education. And we want to then also now ensure that these competencies are also what's being practiced in facilities. And unless facilities are being rewarded for the quality of care and the standards of care that are being actually what ICM is stating as the standards, then we're not going to have that. So that would be one question to ask, is concerns or questions around performance-based financing. The second question that I have, I heard community health workers mentioned, but we didn't talk about them enough, and wanted to provide an excellent example to look at in Ethiopia is the use of community health workers, where they are actually a part of the civil service system. And so they're considered a part of the workforce, paid workforce, and what they have been able to do is quite incredible. That might be an example to take a look at in terms of really an evidence example to carry forth. What's different with this cadre is that these are women and men who are really high school graduates compared to maybe other community health workers that we see where there's not an established baseline standard of education. And then they go the vocational route, where they're then trained with a particular length of time. Thank you for that.
Thank you very much. Just to say, I think that probably the performance-based financing may be discussed in our next panel. And I know we've got a long line, and I'm getting the signal here from Susan that if you don't mind, we'll address those questions that you just raised as we go forward. In the meantime, let me thank the panel, and please join me in thanking our panel.